Friends, we have discussed about the at-risk foot. We have discussed about the sensory and motor neuropathy and how to test for them. We have discussed about the deformities that will pave way for foot ulcerations. The other important area in diabetes and diabetic foot problems is the peripheral arterial disease, also called PAD. Remember, PAD is not only a marker of diabetic foot disease, it is a marker of vascular ill health. It is a marker of coronary vascular disease. Every patient of PAD must be screened for coronary vascular disease. Ankle brachial index of less than 0.9 signifies the onset of PAD. 20 to 30% of patients of diabetes do have ankle brachial index of less than 0.9. Around 10 to 20% of patients of type 2 diabetes do have PAD even at the time of diagnosis. As the age increases to around 50 or more, 30% of diabetics do have PAD, and those who have diabetic foot ulcer, 40 to 60% of them, they have significant peripheral arterial disease. There will be functional disability, there will be functional limitation. There will be decrease in the claudication distance and increasing the intermittent claudication pain. There will be increased risk of coronary artery disease, cerebrovascular disease, and this PAD delays ulcer healing, increases the amputation risk. But of course, studies have shown that PAD per se does not increase the risk of foot ulcer. But having said that, if a patient has foot ulcer, then his chances of delayed healing and amputation are more when the patient has got PAD. The best measure of peripheral arterial disease is ankle brachial index. This should be a common office procedure using your simple sphygmomanometer cuff. Only thing is, we require a vascular Doppler to hear the sounds on the arteries. Here we hear the sounds on the brachial artery, and on the foot we use either the dorsal pedis or the posterior tibial. The cuff should be tied just above the ankle, and measure the systolic pressure in the brachial artery in the right and left arm, and the systolic pressure when we hear the sounds on the foot in both the right and left lower limbs. Having obtained those values, the right ankle brachial index will be higher right ankle pressure, because we read 2 times and take the higher of the 2 and then divide it by the higher arm pressure. Each reading is taken twice. The higher arm pressure will be denominator, higher right ankle pressure being the numerator. Left ABI, again higher left ankle pressure of the 2 readings will be the numerator, higher arm pressure, either arm, either right or left arm, will be the denominator. Remember, we have to do this in a warm room after 10 minutes of rest given to the patient. Vascular Doppler of 5 MHz probe has to be used. Take 2 readings on each of the limbs. Total 4 into 2, 8 readings. Take the higher reading. This is how ABI is calculated. The next table will summarize the interpretation of ABI. Normally, the systolic pressure in the arm should be the same as the systolic pressure at the ankle. So that means the ankle brachial index or ankle pressure divided by brachial pressure should be almost 1. So up to 0.9 it is normal. If the ankle pressure is 90% of the brachial pressure, it is okay. Anything less than that, that is between 0.9 to 0.4, it is a diagnosis of PAD is confirmed. If the ankle pressure is 40% of the brachial pressure or 0.4 ABI, then this is critical limb ischemia. Normally, the ABI will be anywhere between 0.9 to 1.29. Sometimes the ankle pressure will be more than the pressure in the brachial artery. Such a situation, the ABI value will be more than 1.3, and that signifies non-compressible artery. So we are interested in finding out whether the patient has got the ABI of more than 0.9 or it is less than 0.9. If it is less than 0.9, is it between 0.9 and 0.4? When it is PAD confirmed, or is it below 0.4? If it is below 0.4, it signifies critical limb ischemia. Immediately the patient should be submitted for intense vascular investigation to save the limb in critical limb ischemia. There is a small little program on my website which you can download to calculate the ankle brachial index. All you need to do is, this table will be there up for you after you download, and you fill in these boxes on the right side, on the left side, and then the brachial first reading and the brachial second reading, dorsal speed or posterior tibial first reading, dorsal speed or posterior tibial second reading. You just fill up these readings here. So, like in this case, the first brachial reading was 120, second time it was 110, the dorsal speed is posterior tibial 110 to start with, second time 100, and here 126 on the left side, 124 second reading. The pedal pulse pressures were 106 and 108. Once you put those numbers, immediately the ABI is calculated by the program, and it says right ABI is 0.87, left ABI is 0.8, and it gives the interpretation because both the values are less than 0.9, both the limbs there is evidence of PAD. And if it is less than 0.4, it will appear here showing that it is critical limb ischemia. If it is normal, the values will appear here and say normal. If it is more than 1.3, it will appear here and say it is non-compressible arteries. This little program can be downloaded by you and can be used to just work out your ankle brachial index. All you need is a sphygmomanometer and a small vascular Doppler. With those two things, you can do this bedside test and then predict the vascularity of a diabetic patient. Can we infer the level of narrowing of the blood vessels depending on the site of the pain? Yes. If the patient complains of ischemic pain and intermittent claudication in the buttocks and thighs, sure, the obstruction is at the level of aorto iliac blood vessels. If he has got pain in the calf muscles on walking and intermittent claudication in the calf muscles, the obstruction is high above the calf muscles. That means it is femoral. If the patient complains of foot pain or ankle pain, then the obstruction is at the tibiopopliteal level. Rest pain signifies critical ischemia. Rest pain means patient has ischemic pain even when he is not walking. Claudication distance less than 200 meters suggests severe ischemia, and rest pain and claudication distance of less than 200 are direct indications to further investigate the case immediately by a vascular surgeon to do whatever that can be done to save the limb. Can we differentiate a neuropathic ulcer from an ischemic ulcer based on the presentation? This summary table tells us how the neuropathic limb ulcers differ from the ischemic limb ulcers. Neuropathic limb ulcers, painless ulcer, red in appearance. Ischemic limb ulcer, painful ulcer, pale and cyanotic. Neuropathic limb ulcer, normal pulses. Ischemic limb ulcer, pulses are decreased or absent. Neuropathic limb ulcer, typically punched out. Ischemic limb ulcers, they have irregular margins. Neuropathic limb ulcers, often on the sole or margins of the foot. Ischemic limb ulcers, common on the toes. Calluses, bone deformities are a feature of neuropathic limb ulcers. Calluses and bone deformities are usually absent in an ischemic limb ulcer. Sensory impairment or insensate feet are features of neuropathic limb ulcer. Variable sensory findings may be there in ischemic limb ulcer. Feet are dry and warm and with dilated veins in a neuropathic limb ulcer. In case of ischemic ulcer, the feet are cold and the veins are collapsed because of poor blood flow. These are some of the salient features to differentiate neuropathic from ischemic ulcers. Remember, in a given patient, you may have a combination of ischemia and neuropathy, then the features will be mixed. There is another small little test called the venous filling time or the VFT. How do we do it? Ask the patient to sit comfortably and identify a pedal vein bulging above the skin on the dorsum of the foot. Then ask the patient to lay down supine and elevate the leg to 45 degrees for 1 minute. Then again bring him back into the sitting position and check the time for the pedal vein to fill and bulge above the skin. Normally, the pedal vein should fill within 20 seconds. If the filling time of the pedal vein after the above maneuver is more than 20 seconds, it means the arteries supplying the foot are compromised and the entry of blood into the foot is delayed, so much so the venous return also takes longer time. Filling time of more than 20 seconds VFT signifies the ABI is less than 0.5 and the limb is critically ischemic. This venous filling time has got a high specificity. If this is present 95% of the times, we are sure that the ABI is less than 0.5, but the sensitivity is less. That means if the venous filling time is normal, we cannot ensure that the circulation is all right. We have to do an ABI, but the specificity is very high and the likelihood ratio is as high as 3.9.